okay? But I will always advise you to be in class. Don't be missing class, okay? When you are preparing for NCLEX, the things you are studying is bulky, it's a lot. So it is better you don't miss classes. You try and enjoy class so that you learn some things right away in class, right? You learn some things right away in class so that you don't end up going back to them because it will delay you, right? Good. So it is better you always join the class despite the fact that the classes are recorded. All right. So we started our NCLEX review on the respiratory system. Okay, I think 2 weeks ago. We've done COPD, we've done asthma, we've done tuberculosis, we've done what do you call it? Pneumonia and the rest. Okay. Today we will begin or we will continue with pulmonary embolism today. As I said, all the recordings are there. You get them to catch it up with us. Okay. All right. So today we will begin with pulmonary embolism. Okay. So we start for today. May God be with us. Amen. All right. So we are starting for today. All focus and attention should now be on today's class. Please kindly mute up all the time. If you want to speak, if you want something, a question, a contribution, just raise your hand, okay? Or call me, and then, or let me say, unmute, and then you can now speak, okay? So when you raise your hand, I'll call you, you unmute, and then you can now speak, okay? All right, good. All right, that is fine. So exactly 4:10. Let's start today's business. So pulmonary embolism. For pulmonary embolism, another condition that I think that most of us here have an idea on. Very, very easy, and it's very, very common on the NCLEX. Pulmonary embolism, before I even start, on the NCLEX, they usually combine it with a condition we call open reduction internal fixation, ORIF. Open reduction internal fixation. Okay, open reduction internal fixation. On the NCLEX, they usually combine these two conditions. Realize that a patient went to theater and then had ORIF done. ORIF is a procedure usually done for patients with fractures. So a patient comes with, let's say, tibia fracture. Then we send a patient to theater for ORIF. We put on a plate. Then we screw the plate to join the bones. Okay? We screw the plate to just join the bones. But why is it that it can cause pulmonary embolism? Because it can cause pulmonary embolism because after the procedure, patient can bleed. Surgery, bleeding can occur in surgery. So when you bleed in surgery and then some factors come into play, patients can have some clotting. And the one that's clotting, it can distribute to cause pulmonary embolism. So most of the time, I have realized this, I have seen this, that is why I'm saying it. They combine, or per experience, they combine ORIF a lot with what? With pulmonary embolism. Even in kill banks and what we've been seeing, we're reading across, they will combine pulmonary embolism with what? With ORIF. So a patient with theater had ORIF, and then you realize that patient starts showing signs and symptoms of what? Pulmonary embolism. And you know that the patient is having what? Pulmonary embolism. So please just note that. So that when you see ORIF, once you see ORIF on your NCLEX, in case studies, be expecting probably there will be ORIF. It is not in all cases, but about 90%, they will attach pulmonary embolism to it. Okay. All right. So pulmonary embolism, the word pulmonary, once you hear pulmonary, what comes into mind? Either a vein or an artery, right? Or something in relation to the lungs. Let me put it that way. Something in relation to the lungs. So once you hear pulmonary, pulmonary simply means something in relation to the lungs. Then you hear embolism. Embolism is a sudden blockage of a vessel, of a blood vessel. Let me put it that way. A sudden blockage of a blood vessel. Let's say either by clot, either by air, either by fat, they are all embolism. So when your blood vessel, let's say the vein or the artery are blocked by air, by clot, or by whatever, it is embolism. Then pulmonary is something associated with your lungs. So as you can see today, our focus is more on the lungs, issue affecting your lungs, okay, like in pulmonary embolism. So once you even hear or see the name, something just comes into mind that there's something of a blockage relating to your lungs, okay? All right, so pulmonary embolism is a blockage of one or more pulmonary artery in the lungs by a clot, okay? It's a blockage of one or more pulmonary arteries in the lungs by a clot. So here it is specified. Pulmonary embolism specified by a clot. Okay, by a clot. So as I explained, when you have one of your what do you call it, your arteries being blocked by what, or your blood vessel being blocked by a clot, the pathophysiology is not something strange or special. Okay, so the pathophysiology for pulmonary embolism is that a patient, let's say for example, went to theater for ORIF. Then the patient went for ORIF, they were cuttings, or let's say they were bleeding. So the patient bled. So after the bleeding, there were clot formation. But for whatever reason, the clot was not broken down normally. Or let me say the clot stayed there and it was able to travel through circulation. Okay, once I say circulation, let me go over circulation briefly. Okay, to understand this properly. You know, we have basically two forms of circulation, systemic and then pulmonary, right? It's pulmonary circulation, systemic circulation. Now, where that blood begins from, it begins from the inferior vena cava, superior vena cava. Right from the inferior vena cava, superior vena cava, it goes to the right atrium, right? From the right atrium toward the tricuspid valve to the right ventricle. Then from the right ventricle, it is going to the lungs. But how can the blood go from the right ventricle to your lungs? It passes through the pulmonary vein, the pulmonary artery. Okay, right, the blood, right from the blood leaving from the right ventricle, it passes through the pulmonary artery to your lungs. Okay, so if the pulmonary artery is blocked by a clot, blood will not flow properly to your lungs. And the one thing you should also know is that once you go for theater or for whatever reason, clot forms, let's say somewhere in your vein, in your legs, in your thigh, they can travel through the inferior vena cava and then can block the pulmonary artery. Once it blocks the pulmonary artery, it inhibits blood flow to your lungs. So there will be no perfusion, or there will be no proper perfusion to your lungs. They will say you have pulmonary embolism. So that is the whole pathophysiology. A blockage of a clot inhibiting adequate blood flow from the right side of the heart, right ventricle, to the heart, and then we say pulmonary embolism. So you begin to show signs of what? Embolism or pulmonary embolism, which we'll get there very soon. All right, then my next question is, what about air and fat? Air embolism is simply when air blocks an artery or blood vessel or a vein. Okay, it is air. And this one is usually common when you are giving injections or an infusion. So you set up an infusion on the patient, you didn't expel air. That is why anytime you're about to set an infusion, you expel air. If you don't expel air, what is going to happen? You will end up pushing air into the patient vein. Once air enters the patient vein, it can interrupt blood flow. We say there's air embolism. Then we have fat embolism. Fat embolism occurs when fat deposits also travel through your bloodstream and impede or obstruct blood flow. Okay, it impedes or obstruct blood flow throughout your body. And fat embolism is usually caused by a fracture of a large bone or a long bone. So I'm giving you an ankle tip. Most of the times, if you will see fat embolism on the ankles, patient might have had a fracture of the hip or femur. Please take note. When you start reading the question tells you a 55-year-old man admitted to your ward with a fracture of the hip, of the femur, or let me say femur, how you pronounce it, depending on where you completed your nursing school or GHS. Okay, femur or femur, however you pronounce it. So a fracture of the femur, hip. Then you read on, patients start having issues like difficulty breathing. Please, this is fat embolism. Okay, once you see fracture of the femur, most of the times, fracture of the hip, most of the time it is fat embolism. It is typically fat embolism. So please take note. Now, how does this occur? So when you get fracture in the large bones, like the femur, the hip, there are some fat deposits in there. So when you get fracture of the hip, fracture of the femur, and you don't immobilize the limb, you don't put the limb at one side, you don't put the patient on one side, and the patient keeps on moving the body here and there, eventually the fat deposits in the bone get dislodged into the bloodstream and you begin to obstruct blood flow. You begin to get fat embolism. That is how it comes about. When you see fat embolism, that is how it comes about. A patient comes with a femur fracture, then you didn't immobilize. The patient keeps on moving the leg here and there. Eventually, fat deposit in the bone begins to get released into the bloodstream. Then it gets to your lungs, it gets to blood vessels, restricting blood flow to your body and other parts of the body. You get what? Fat embolism. So that is how fat and air comes about. So right now, you've been able to distinguish between pulmonary air embolism and fat embolism. Am I right? Is there any question? Any question? Okay. All right. So I presume there's none. Or can you hear me? Please, can you hear me? Let me first confirm if you can hear me first.
Yes, Bosaki, we can hear you. I
All
can
right.
hear you. Mhm.
Okay.
Bosaki,
Yeah.
Bosaki,
Yeah. Madam Ben is here.
please can you go over the embolism for me?
Yeah. What
Yeah,
I'm
the
saying about,
embolism.
yeah. So for the air embolism, it comes about when air gets trapped into the blood vessel. Okay, when air gets trapped into your blood vessel, either your vein or your artery. So a typical example of how it can come about is through infusion. You are about to set up an infusion on a patient. You didn't expel air. You didn't expel air. Then air gets into your vein. That is what comes about, or that is what causes air embolism. So the air will get trapped into your blood vessel, then you get air embolism. So when you air gets through your vein by way of infusion injection, okay, and it blocks adequate circulation, we say there's air embolism. Now, let me give you the intervention, the best intervention before you even continue. How do you solve or how do you manage air embolism? You can do this by putting the patient on the left limbic position. Okay, please. Oh, someone is writing on my screen. Please kindly stop writing on my screen. Is it Mary, Madam Mary, or someone like that? Please, can you hear me? Are you following? Okay, all right. That is fine. So, yes, you put the patient in the left limbic position with the head down. With the head down. That is the best way to get or to solve air embolism. Okay, so left. I'm just typing in the chat box so that when you see it, left and level position with the head down. Okay, this is how you solve air embolism as fast as possible, so that blood can flow through your blood vessel. So you get a question. A 55-year-old patient was admitted to your ward, and then it was supposed to receive IV fluid. Then upon upon administration of the IV fluid, you realize that patient was having difficulty breathing, poor circulation by way of improper capillary refill. Then you realize that the patient there's air in the tube. You realize that there's air in the tube. What comes to mind? Air embolism. So quickly, what do? You put the patient in the left lateral the trilembic position or left trilembic position with the head down. This will cause the air to become trapped in the right atrium, then it will leave out. Okay. So it will become trapped in the what? In the right atrium to prevent it from going to the pulmonary artery. I told you that when the blood leaves the right atrium, it goes where? Right ventricle, then where? Pulmonary artery. So when a patient gets air embolism and you position in the left trilembic position, the air gets trapped in the right atrium so that it doesn't go to the pulmonary artery. Then this can help solve the situation. Okay, so please take note. Please take note of that. All right. So that is that. Today we are not doing air embolism and fat embolism. We are doing pulmonary embolism. Let's focus on pulmonary embolism. Okay. All right. So that is that. That is that. All right. Let's continue. So please, you all get the pathophysiology of pulmonary embolism, right? It's when a clot, to be specific, clot gets trapped into a blood vessel or your artery, and then especially the pulmonary artery, preventing adequate blood flow from the right atrium to your lungs, and then you begin to get symptoms. Okay. All right. Now, what are the causes, the basic causes of pulmonary embolism? So one, blood clots. okay, blood clot is the basic risk factor, of course. So most pulmonary embolism. So please, if you hear me say PE, if you hear me say PE, I mean pulmonary embolism. I might not be able to keep on repeating pulmonary embolism. I might say PE. So when I say PE, I mean pulmonary embolism. So most PEs are caused by blood clots that form in the deep vein of the leg or other parts of the body. Okay, so the most common portion, the most common portion in your leg where DVT occurs is the saphenous vein. SA saphenous vein is the most common vein where DVT occurs. Okay, so when there's a clot in your vein, it can travel through circulation. I told you through the inferior vena cavus. Okay, through the inferior vena cavus, and it can travel to your right atrium, to your right ventricle, and then it can get blocked in the pulmonary artery and can cause what? DVT. Pulmonary embolism, right? Good. So one, blood clots. Two, DVT, deep vein thrombosis. So DVT is a blood clot that forms in deep veins, often in the legs. So as we all know DVT, when there is a clot in the vein, preventing adequate blood flow from your feet upwards to your heart. Okay, this is DVT. Okay, all right. So DVT is also a risk factor. Okay, so you know all these risk factors I'm mentioning, you can categorize them under the virtuous triad, as you can see on my screen. The hypercoagulability state, the vessel injury, and then the venous stasis. All these risk factors I'm giving falls under the virtuous triad, okay? The virtuous triad. The triad that consists of the causes that really cause what? Clottings to form in the human body, virtuous triad. Right. So two, DVT. Three, recent surgery. I told you already. Recent surgery. A patient goes for what do you call it? A patient goes for what do you call it? ORIF, open reduction internal fixation. A patient goes for CS. Patient goes for whatever surgery. Okay. Then it forms clot. Then the clot gets disturbed in the bloodstream. It gets blocked in the pulmonary artery. It can also lead to what? We call it pulmonary embolism. So recent surgery can cause it. Four, prolonged immobility. For so many times, you've not been walking. For example, someone who works in an office and then sits on the bottles for, let's say, 5, 6 hours, 7 hours without walking, what is going to happen? Blood will begin to pool in your veins, right? Yes, like swimming pool. So blood will begin to form, blood will begin to collect, it begins to pool. Once the blood begins to collect in your vein, because for a long time you don't walk for proper flow. So when the blood begins to form or collect in your body, they begin to clot because it has stayed there for long. So anytime blood stays for a particular place for long, it begins to clot. So prolonged immobility, for example, you've been standing for long, like a military officer who stands for long and does not move about. What is going to happen is that eventually you begin to cause the blood to pool or collect at one place. It can form clots and it can lead to pulmonary embolism. 5, pregnancy. How does pregnancy causes pulmonary embolism or PE? It's simple. When you are pregnant, what happens to your uterus? It becomes big. What is going to happen to the growing uterus in your body? Once the uterus begins to grow big, it begins to compress major vessels around your thigh. Plenty of people are women over here, okay, mothers as well. You know how a growing uterus can stress you. One of the things that happens in your body in pregnancy is that the growing uterus, the big uterus, can begin to compress on some tiny veins and arteries around your thigh, your femur, and a place. When this happens, blood flow from your leg upwards can get obstructed because the growing uterus is compressing on the blood vessels. So it doesn't allow proper flow of blood upwards your body. So when that occurs, the blood also does not come, it pulls and it begins to form clots. Okay, so the growing uterus compresses on some of the blood vessels, and then once it compresses on them, blood does not flow properly, and it can lead to what? Clot formation, and hence PE. 6, obesity. Obesity in general, fat deposit, right? So you are becoming fat, you are growing fat, you are beginning to get fat. I mean, you are overweight. What is happening to your body is that at the point that there's going to be fat deposit or fat accumulation. When the fat accumulates and there's fat adipose tissue, plenty adipose tissue, what happens is that it has an effect on your clotting. In fact, Too many people with obesity have issues with their clotting. Why? Because obesity causes your blood to do what? To clot faster. Okay, obesity can cause a lot of inflammatory processes and cause your blood to clot faster. And you know another thing about obesity? Obesity inhibits the body's ability to break down clot. So too many obesity fat deposits, it inhibits the body's ability to even use their own clotting factors, so they don't clot the blood. So too much obesity or fat can inhibit how the body breaks down clot and therefore can form clot and can lead to what? Can lead to PE. 7, smoking. All right, so if you're smoking for long, I mean, cigarette, weed, whatever, what happens is that a lot of chemicals, these chemicals can begin to affect the integrity of your blood vessels. It becomes weak, it becomes thin, it becomes narrowed. Too many smoking can begin to affect the integrity because the chemicals in the smoke can begin to affect or narrow your blood vessels. And if your blood vessels are narrowed, do you think blood will flow properly through your blood vessels? No. So it can meet some resistance, form clot, and can lead to what? PE. Then we have 8, oral contraceptives. Oral contraceptives, we have estrogen. Estrogen is found to cause a lot of what? Blood clotting in the human body. In fact, estrogen stimulates the liver to produce more clotting factors. When you take more contraceptives, okay, you don't want to get pregnant, we're taking contraceptives all the time. There's estrogen in it. Estrogen can stimulate your liver to produce more clotting factors and can lead to what? Clottings and PE. Then lastly, we have malignancy, which is cancer. Okay, cancer is also a risk factor to causing what? PE. Actually, malignancy or cancer can put you at a hypercoagulability state whereby your blood begins to clot faster and can lead to PE. So these are some risk factors. But I tell you, the most common you can see on the NCLEX, DVT after ORIF. Please take note, DVT after ORIF. All right, so that is that for the causes and risk factors. All right, any question? If not, let's continue, right? Good. So 1, what are some of the clinical, yes, mommy?
Estrogen stimulates the liver to do what?
To
Sorry,
produce
I
more
didn't
clotting
get that
factors.
Come again?
To produce more clotting factors.
Oh, okay. Thank you.
Welcome. All right. Okay, so clinical features of pulmonary embolism. 1, shortness of breath. Sudden onset of shortness of breath. Why? There's impeded blood flow to your lungs. There's impeded blood flow to your lungs. Your lungs are not perfused.
I have a question.
Okay.
You said no, the previous slide. You said deep vein thrombosis and what ORIF? I didn't get that part.
I was saying that usually on the NCLEX, what they usually bring as risk factors and causes of pulmonary embolism is 1, DVT. Mostly after a patient undergoes ORIF. ORIF is an open reduction internal fixation, a surgical procedure. After the patient undergoes that procedure, they usually get DVT because there's going to be clot in your legs. So when
the ORIF is what?
A surgical procedure whereby
the full meaning
is open reduction internal fixation.
Okay.
Yes. So you can get a fracture even on your hand, your legs, wherever. They will just open your leg and then put plates on top. Okay. And they will put screws like a fixator. They will put screws to hold the bone so that it can heal. So that is the procedure. Okay. Yeah. If you want to observe some, you just come to my hospital. We do those things a lot. Okay. Madam Bennett will tell you. All right. Okay. All right. Okay. That is fine. So that is it. So clinical features. So 1, shortness of breath. Okay. So sudden onset of shortness of breath. A patient is having pulmonary embolism. There's an issue with the lungs. The lungs are not perfused. You are not getting adequate perfusion in your lungs. Do you think that you will get proper oxygenation? Because contained in your blood is hemoglobin. Hemoglobin should be moving around your body to perfuse organs for proper oxygenation. Here lies the case, there's an obstruction in the pulmonary artery. Therefore, the lungs cannot be perfused properly. One thing about pulmonary embolism is that you can breathe in air normally. You can breathe in air normally, but you don't need the air alone for proper oxygenation. You need perfusion as well to combine to give you proper oxygenation. But here lies the case, you have a blockage in the pulmonary artery and the blood does not go to your lungs, okay, to even get perfused. What is going to happen? And then let me even tell you, do you know that all the blood coming from the pulmonary artery to your lungs are unoxygenated? Do you know that? Yes. Way back, then let's go back, okay, biology, okay. All arteries carry oxygenated blood except pulmonary artery. Don't forget, okay, all arteries carries oxygenated blood except pulmonary artery. So when a pulmonary artery is bringing the blood, it is not oxygenated, it doesn't contain oxygen. It is when it gets to your lungs before it gets oxygenated by your lungs to perfuse your other body. Now, we are not getting the blood to your lung to get the perfusion to supply the rest of the body. So do you think your kidneys, your other body can even get perfused? No. You try to do something small and then you are not getting oxygen because we are not getting proper flow of the blood to even perfuse our body. The blood that should enter your lungs to get perfused so that it can supply the rest of the body are not coming. So you don't get proper flow of the blood to perfuse other part of the body. Little thing you do, you are tired because there's no oxygen, there's no proper blood flow. So you can get shortness of breath as first sign. 2, chest pain. Sharp chest pain that worsens with deep breathing or coughing. Of course, there's a blockage. There's a blockage. And then let me tell you something. Once there's a blockage in the pulmonary artery, the lungs are not perfused. What do you think is going to happen to the lungs? It begins to die. Tissues in your lungs begins to die. First of all, they begin to get injured and begins to what? Get traumatized and they begin to die. So when your lungs is dying and you are breathing in or you are coughing, you are breathing in deeply, your lungs is dying, you begin to feel severe pain in your lungs, which can now be radiated to your chest. If something is trying to die, there's improper flow of the blood to a portion of the body, you begin to feel pain first because there are no proper perfusion. Then eventually it begins to die. Okay, so please take note. The tissues start dying, it causes pain because the lungs are not perfused. So when you breathe in deeply, this can cause pain, and even when you cough on your chest. 3, coughing up blood, hemoptysis, okay, or frothy sputum. Yes. Frothy sputum. In which condition, this one I'll ask a question, I'll not say it. In which condition do you usually see pink frothy sputum on the anklet? Yes.
Pulmonary edema.
Pulmonary edema. Okay, she is right. So when a patient comes with heart failure and then they get fluid into their lungs, they get pulmonary edema. How do you know patient have pulmonary edema? In fact, anklets like bringing this. They will bring pink frothy sputum. Please, this is pulmonary edema. One thing too, okay? Pulmonary edema. All right. So you can get frothy sputum, but please let me just repeat again. Frothy sputum is more associated with pulmonary edema. In fact, pink frothy sputum, let me be specific. Pink frothy sputum, more associated with pulmonary edema. Please take note. All right. So coughing up blood is hemoptysis. Okay. Other word is hemoptysis. So patient will automatically cough up blood. Why? Because the lungs are getting injured, they are getting damaged, so they begin to bleed. Tissues are dying, so they begin to bleed internally. So when a patient cough, they can cough out blood because something is causing the lungs and the tissues are not getting perfused. So automatically the tissues begins to start get injured. They start getting injured, and then they begin to get deaf, or they begin to die. Once it begins to die, what happens before the ultimate death is that they can begin to bleed because there's going to be injury, pain, injury. So this can cause them to cough up blood when they are out, when they are coughing. Okay, so this is why they have hemoptysis. 4, tachypnea. This one is a compensatory mechanism. Patient is having issues with their breathing, they have shortness of breath. So patient will have to compensate. The body will be like, hey, Charlie, this is not how I was created. I don't know why I'm having difficulty breathing. Let me do something. The kidneys are suffering. They need oxygen. So they begin to compensate, and then they begin to what? Have high breathing levels, which is tachypnea. 5, hypoxemia. Hypoxemia. So eventually, you don't get enough perfusion, okay? You don't get enough oxygen in your blood because the lungs will not get perfused. It begins to die, which will not allow proper oxygenation into your blood. You get hypoxemia. 6, change in mental status. We all know that for you to think as a normal person, you need oxygen. The brain needs oxygen. In fact, let me tell you, this is why brain death is only common in unconscious patients. And people usually who have serious cessation of breath. You see, the least thing that will occur where a patient's breath is ceased for long, they can get brain death or even brain damage because you need oxygen in your brain to think, to function as a normal person. So if you have issues with oxygenation, you begin to get confused, you begin to get agitated, restlessness, because the brain is not getting enough oxygen, okay? So there's going to be change in mental status. 7, hypotension. Of course, there's going to be hypertension, of course, because you know, when you don't get adequate blood flowing through the pulmonary artery to your lungs, how can the lung even get the blood sent to the aorta to pump for cardiac output? If you don't get proper flow of blood from your artery to your lungs, so that your lungs will get correct volume sent to the aorta after everything to pump to the proper or the rest of the organs, causing cardiac output. Do you think there's going to be proper or enough cardiac output? No. So there's going to be what? Hypotension, because there's a blockage in the pulmonary artery. Then 8, good. This point, I left this point here for some reason. Okay, the reason why I left this point here is that petechial rash or petechial rash on the chest is not mostly common in pulmonary embolism. No, it is common in fat embolism. So sometimes the ankles try to confuse you. You will see difficulty breathing, you see change in mental status, then you see petechial rash on the chest. Please, if you see petechial rash on the chest and the patient had a fracture of the femur and the hip, please pick fat embolism. Sometimes I know in some books, they try to say patient with pulmonary embolism also get petechial rash. That is why I intentionally left this here to just clear some little confusion. But just note that, see, petechial rash is mostly common in fat embolism more than pulmonary embolism. So when you see petechial rash on the ankles, mostly it goes for fat embolism. Okay, mostly it goes for fat embolism. But let me just give you this disclaimer. Let me give this disclaimer. If you see petechial rash on the chest, coupled with shortness of breath, coughing up blood, tachypnea, and the patient is having DVT, please just settle for pulmonary embolism. You just go for pulmonary embolism. But then, if you see several options, and then you see petechial rash, shortness of breath, chest pain, and the patient had a fracture of the femur, go for fat embolism. Is it clear? Please, is it clear?
So
Is it clear?
Come again with the pulmonary embolism, please.
I said that if you see petechial rash on the chest, shortness of breath, chest pain, in an option, and the patient had DVT, please go for pulmonary embolism. That is 1. So you see petechial rash, hypotension, change in mental status, and the patient had DVT previously, go for pulmonary embolism. Again, when you see petechial rash on the chest, change in mental status, hypotension, and the patient had a fracture of the femur or the hip, go for fat embolism. Clear, right? Now, when you see petechial rash on the chest, change in mental status, tachypnea, and the question does not specify whether the patient had DVT or fracture of the hip or femur, but in the options, you see A, pulmonary embolism, B, fat embolism, please go for fat embolism. Please, is it clear? Please, is this thing clear?
Yes, sir. It's clear.
So if you see in the options, a 55-year-old man was admitted to your ward. Per your assessment, you observe these signs and symptoms. A, shortness of breath. B, you observe this and the same thing, shortness of breath, chest pain, petrician rash on the chest. The question didn't specify or mention anything like fracture or DVT or anything in the question. None of them was mentioned. And you see in the options, A, pulmonary embolism, B, fat embolism. Please go for fat embolism and not pulmonary embolism. All right, good. Any question on this slide? Okay, I guess there's no question. All right, let's continue. Diagnosis. How can you diagnose pulmonary embolism? One, CT pulmonary angiography. Okay, so you do a CT scan that uses a contrast dye to visualize your pulmonary arteries. It's simple. Okay, you just do a CT scan that uses a contrast dye to visualize your pulmonary artery. So they want to see your pulmonary artery. Is anything like a clot in there? Is something blocking the flow of the blood in your pulmonary artery? So you can do a CT or a CT scan of the pulmonary arteries. Okay, so this is what we call CT pulmonary angiography. Two, you can do a ventilation perfusion scan. Okay, a ventilation perfusion scan. A ventilation perfusion scan. So it is a scan that evaluates lung function and blood flow. So in this scan, they will do two separate scans. They do two separate scans. They do a ventilation scan and they do a perfusion scan. In the ventilation scan, they let you, swallow or inhale, not swallow, inhale a harmless radioactive dye, right? It is harmless. It doesn't cause anything to your body. So you inhale it. Once you inhale it, they will bring a tracer to trace the amount of air you breathe in into your lungs, right? Then the perfusion scan, they will inject a radioactive this thing as well into your blood. Then it also attach itself to a tracer to trace how blood flow to your body, through your pulmonary artery to your lungs. Then after this thing is done, this scan is done, this ventilation perfusion scan is done, the head and tail is that there's going to be what we call ventilation perfusion mismatch. And so in pulmonary embolism, you will get ventilation perfusion mismatch. Why mismatch? Patients can breathe in air normally into the lungs, but then the blood that should support the perfusion of the lungs is not there. So you realize that adequately, patient can breathe in air, but then there's inadequate supply of blood from the pulmonary artery to your lungs. Then there's a mismatch. So there's going to be a ventilation perfusion mismatch after this scan. All right, 3, D-dimer. So D-dimer, a blood test that measures the levels of D-dimer, a protein produced when blood clot dissolves. Okay, so under normal circumstances, the human body can break down clots, right? Yes, under normal circumstances, your human body can break down clots. It is something in our human body, naturally. You can break down clots. So when you get pulmonary embolism, the body will try to fight to break some of the clots, okay? Anytime a clot is broken down, you get a protein called D-dimer. So one way we can diagnose pulmonary embolism is to do a D-dimer test so that we can see if there's a large amount of this protein in your blood, telling us that the patient is having what? A clot breakdown or pulmonary embolism. Okay, so we can do a D-dimer test, and then usually it's going to be very, very, very high. Okay, it's going to be very, very high. Then we see that the patient is having what? Is having a pulmonary embolism. Therefore, arterial blood gas analysis. Okay, arterial blood gas analysis. So what do you think the patient will get? Is it respiratory acidosis, respiratory alkalosis, or what? Yes.
Acidosis. Respiratory acidosis.
Are you sure? Are you sure?
The question again. The question again.
Do we get respiratory acidosis or alkalosis in pulmonary embolism? Yes. Let me go back, and then I'll give you a clue. All right, point 4. Look at point 4. Point 4 is tachypnea. Point 4 is fast breathing, tachypnea. So if you are breathing fast, what happens?
Alkalosis.
Yeah. Please take note. Please, don't get confused or don't get. I mean, it's not difficult. Okay, it's not that difficult.
Boss
Sometimes,
Aki,
yes.
I was thinking that there will be accumulation of carbon dioxide, which will lead to
How?
acidosis.
How? Explain how.
Because patient is not, although, like you said, the mismatch, although
Mm-hmm.
patient is getting the oxygen,
Uh-huh.
like you are giving the patient oxygen, but it's not going to the system because there is a blockage. So there
But
will be
is it
buildup of carbon dioxide in the
where?
blood.
Okay, where is the blockage? Where is the blockage?
It's either the bronchial, like the
No, no,
airway.
no, no. The blockage is in the pulmonary artery, not the airways. Okay, the
Oh,
blockage is
okay.
in the pulmonary artery, not the airways. Okay, yes,
Okay.
the blockage is going on in the pulmonary artery, so air can enter. That is why I told you there's ventilation properly, but perfusion is not going well. That is why you have the mismatch. So air can enter, and once the air enters into the alveoli, meaning that air can also come out. The whole point is that there's improper perfusion from the pulmonary artery to your lungs. But for air, it can enter your lung properly and can come out. So here there's going to be respiratory alkalosis. Why? You begin to pant. There's shortness of breath. There's difficulty breathing. So you begin to breathe faster to just balance the issue or to compensate. So fast breathing begins to cause more carbon dioxide to come out. Don't forget, you breathe in oxygen, breathe out carbon dioxide. So the more you breathe out, the more you bring carbon dioxide out. So you are breathing fast. You eventually you bring more carbon dioxide out. Then you will left it. You bring yes, more carbon dioxide out. So CO2 will be blown out. Then it's going to lead to what? Respiratory alkalosis. Okay. All right. So you are bringing all the acid out because CO2 stands for acid. So the more you bring the acid out, the more you leave the base, causing respiratory alkalosis. So please take note. All right. Then 5, you can do a duplex venous ultrasound of the legs. Okay. A duplex venous ultrasound of the legs. So I'll do an ultrasound of the legs to see if there's adequate pulse, if there's no clot in your legs causing DVT to prevent blood flow. So that is what you should know about duplex venous ultrasound. So these are the tests you can know for what? For pulmonary embolism. Please take note, in pulmonary embolism, you are getting respiratory alkalosis because of hyperventilating. You are breathing faster to compensate. Okay, all right. Now, next interventions, what should you know as a nurse? Okay, next intervention, what should you know? 1, keep clients in high Fowler position. Keep clients in a high Fowler position. I think from the beginning of our class till now, you should know why if the patient have respiratory issue, we keep them in high Fowlers. Why? Because we want the lungs to expand. The more the lungs expand, the more there's proper breathing. So keep patient in high Fowler position to expand the lungs. 2, teach the client the need for long-term oral anticoagulation because there's a clot blocking blood flow. So we can give them an anticoagulant, which will go over them very soon. Okay, we can give them an anticoagulant. 3, administer supplemental oxygen. So patient is not getting perfused, organs are not getting perfused, so limited oxygenation. So sometimes you can give patient or you can supply additional oxygen to the patient. 4, monitor patient respiratory status. Of course, someone having issues with respiration, with breathing, you should monitor respiratory status. Then next point, use a vena cava filter in cases where anticoagulants are contraindicated. Okay, let me just anticoagulant. Okay. How do I even put it? Okay, 1. In what cases are anticoagulants contraindicated in the patient? 1, when the patient is bleeding. you don't give anticoagulant. Patient will bleed more. So in this case, stop anticoagulant. Use a vena cava filter. You place it inside a vena cava. It will collect all clots and prevent them from entering the right side. Even it will not even get the right atrium. So 1, when the patient is bleeding. 2, hemophilia. Yes. When patient has hemophilia, you can't give anticoagulant. So you can use a vena cava filter to collect and stop all the clots so that it doesn't even go into the heart. Okay. A lot of instances, in fact, okay, when patients, okay, for bleeding because it's fine. Yes. So even when the patient is sometimes going for a surgery, we hold anticoagulant, right? Yes. So that the patient will not bleed when they go to the theater. So in all these instances, you don't give anticoagulant, and then you can use a vena cava filter. It's a filter like a funnel. If you are pouring water and you want to use a funnel, what does it do? It collects all the dirt so that the dirt does not enter the water. So same way, filter will collect all the clot so that the clot does not enter your blood to your heart. That's all. All right. Pharmacology. What are some of the pharmacology that you should know for pulmonary embolism? 1, anticoagulation therapy. Anticoagulants. So medications that prevent further clotting, which is heparin. You even have warfarin. They are all the same. Heparin, warfarin. They prevent future clot from forming. Okay? They prevent future clot from forming. Okay? Heparin, warfarin prevent future clot from forming. 2, thrombolytics therapy. Medication that can dissolve clot. Example, alteplase. Please, these drugs are what we call clot busters. They can break down clots. It's like a hammer. Okay, it's like using hammer to hit a stone. You see how the hammer breaks the stones into pieces. Same way, this drug, it can break the clot into pieces, little pieces. Okay, good. Then 3, we have analgesics for pain. Then 4, statins if they are fat. So for example, fat embolism, or if the patient is having too much fat in the body, you can give statins like atorvastatins. Okay, right. Then 4 or 5, you can do what we call embolectomy, a surgical procedure whereby you do to remove the blood clot from your pulmonary artery. That is embolectomy. Okay, a surgical procedure being done to remove clot from your artery or vessel is what? Embolectomy. All right. Now, good. This is a common anklet step that we should all know for our anklets. Warfarin and heparin, or heparin and warfarin, they are all anticoagulants, right? They are all anticoagulants. What does it do? It stops future clot from forming, or it stops clot from forming. Okay, it stops clot from forming. There are some key differences you should know for your anklets. Okay, there are some key differences you should know for your anklets. All right, so let's go through them. 1, onset. Heparin has a rapid onset. In fact, within minutes, it starts to work. Whereas warfarin has a slow onset. It can take hours to days before it can start working. But heparin has a rapid onset. So please take note. Difference between heparin and warfarin. The duration. Heparin is usually used for short term, usually 4 to 5 days. But then warfarin can be continued for a week or beyond. Do you know we can use both of them together? You can give heparin and warfarin together at the same time. You can give both of them at the same time. Okay. But then usually after some few days, like what you can see on my screen, after some few days, you can stop the heparin and you continue the warfarin. Okay. So heparin has a short term. I mean, you can just use for short term, like 4, 5 days, you stop. Whereas warfarin can be used for longer periods. Okay. All right. So when you are giving heparin and warfarin, what do you monitor as an RN? What should you monitor? 1, under heparin, you monitor APTT, activated partial thromboplastic time. See, sometimes you see PTT. Please, they are all correct. If you see PTT or APTT, they are all correct. They are all correct. And please, the therapeutic range for the APTT for heparin is 46 to 70 seconds. Okay, Please take note. PTT for heparin, okay, is 46 to 70 seconds. So please take note. It shouldn't be less. It shouldn't be more. Okay, it shouldn't be less. It shouldn't be more. 46 to 70 seconds. Okay, good. 46 to 70 seconds. So you monitor PTT or APTT for heparin. Then warfarin, you monitor PET and INR. They are anticoagulants you can give in pulmonary embolism or even any condition at all whereby there's clottings. Okay, yes. So you monitor PET, prothrombin time, and then INR for what? For warfarin. Okay, PET, prothrombin time, and then INR for warfarin. So the normal PET is usually pegged at 9 to 11 seconds. Okay, PET 9 to 11 seconds. 9 to 11 seconds. And then INR. The INR, let me stop. Let me hold on a bit. I'll have some explanation to give here. Okay. So PT is what? It's 9 to 11 seconds. Most of the times, you peg PT at 9 to 11 seconds. Now, INR. INR, what I would say is that anytime you are giving a patient an anticoagulant, for example, warfarin, and then you are monitoring the patient's INR, please, you peg the normal INR at 2 to 3. Let me repeat. The moment a patient is placed on a warfarin, now the normal INR becomes 2 to 3. But then in a normal human being who is not taking any warfarin, please, the INR is 0.8 to 1.1. I repeat, under normal circumstance, a patient INR should be 0.8 to 1.1. But the moment we put you on a warfarin, it changes to 2 to 3. Please, is it clear? Hello, class.
Please come again.
Yes.
We are listening, sir.
Hey, okay. So I'm saying that under normal circumstance, someone who is not taking, like you and I, let's use ourselves an example. As I'm sitting here, I don't take warfarin. As you are listening to me, you don't take warfarin. You don't have any warfarin you're taking. So for you, if you are supposed to check your INR right now, it should be 0.8 to 1.1 in between this reference range, between this period, or between this, let me see, reference, 0.8 to 1.1. But the moment you put a patient on a warfarin, now you are changing the blood flow. So now, once you put the patient on warfarin, it becomes 2 to 3. Now, you should peg it at 2 to 3, not 1.1 again, or 0.8 again. So once the patient is taking warfarin, you now have to measure their INR between 2 to 3. The INR is the international normalized ratio, right? You now have to measure in between 2 to 3 instead of the normal 0.8 to 1.1. Why? Because now you are giving an anticoagulant. All right, that's all. Pregnancy. So heparin can be given in pregnancy, okay? Heparin can be given in pregnancy, but warfarin is contraindicated in pregnancy. Please take note. Heparin can be given in pregnancy, but warfarin is contraindicated in pregnancy. Antidote. The antidote to heparin is protamine sulfate or protamine sulfate, okay? The antidote to heparin is protamine sulfate, whereas the antidote to warfarin is vitamin K, okay? The antidote to warfarin is vitamin K. So if you give warfarin and the patient is bleeding, you want to stop it, you give vitamin K. All right, therapeutic level, 46 to 70, I think I said this already. All right, then the route to give heparin, IV or subcut, okay? IV or subcut. Then the route to give warfarin, only orals. Only orals for warfarin. Only orals. Only orals for warfarin. Only orals. Now, let me say something about the vitamin K for warfarin. You know that there are a lot of food substances that we get vitamin K from, right? Plenty food substances that we can get vitamin K from. Plenty. Okay? Yes. So sometimes when you are giving warfarin, a patient eats plenty vitamin K foods, what is going to happen? Automatically, you are introducing the antidote. Patient is consuming more vitamin K foods. So automatically, you are introducing the antidote to counter the warfarin. But meanwhile, we need the warfarin to help us with pulmonary embolism. So what do? Do you have to reduce vitamin K rich foods? No, you don't reduce that one too as well, because you need a certain level of vitamin K in your blood so that the warfarin can function properly. Okay, you need a certain level of vitamin K in your blood so that the warfarin can function properly. You shouldn't increase it, you shouldn't decrease it. It should be level, because if you increase the vitamin K rich foods, what will happen is that because you are increasing the vitamin K, it will automatically serve as an antidote that can block the warfarin. And then the other side is that when you reduce it, then it means that the warfarin is not having anything to fight it. You are giving warfarin, and then you are not taking anything at all that includes vitamin K. It means that actually the warfarin has free flow. So the warfarin will be like, okay, since this patient is not taking anything that contains vitamin K, Charlie, we have free flow. Let's move. Let's cause bleeding. Let's kill the patient. Let's cause bleeding. So they'll begin to cause severe bleeding because you don't take vitamin K rich foods. So you need some level of vitamin K to help the warfarin to work properly. So you don't increase the vitamin K rich foods, you don't decrease it, you maintain it at the same level. So a patient is being discharged, a 65-year-old man admitted with pulmonary embolism on account of severe smoking is being discharged on warfarin. Which of the statements made by the patient signify correct understanding on warfarin? A, I will ensure that I maintain my level of vitamin K rich foods. Please, the correct answer. This is the correct answer. I will ensure that I will maintain my level of vitamin K rich foods. I will not increase or decrease it. This is the correct answer. This is the correct answer. All right, let's move on. Complications of pulmonary embolism. 1, respiratory failure. Okay, respiratory failure. So large pulmonary embolism can cause respiratory failure. At a point in time, the lungs will not be perfused, the tissues will die. Patients get respiratory failure. Okay, the lungs can die. 2, cardiac complications. Of course, you can even get right-sided heart failure out of this, because the blood that is passing through the pulmonary artery, first of all, leaves the right atrium. Then the right atrium the blood is leaving the right atrium, all right, but then it is not passing through the pulmonary artery. There's a blockage. So all the blood will backflow. Because under normal circumstance, once the blood leaves the right atrium, it must go through smoothly through the pulmonary artery. But then here, there's a blockage in the pulmonary artery. So they don't go smoothly. So they begin to backflow into the right atrium. The blood can stay in the right atrium and can cause right-sided heart failure. Okay? So we can get what? We can get cardiac complications. Then we can get pulmonary infarction. Pulmonary infarction. Infarction, the word infarction is an English word, and it simply means what? Necrosis, death of tissues. So the lungs can die if there's proper or there's improper perfusion. Then lastly, I even said it, 4, right-sided heart failure can occur because the blood will backflow. So this brings us to the end of pulmonary embolism. Any question on pulmonary embolism? Are we good? Are we all on the same page? Are we understanding everything? So nobody has a question, right? Nobody has a question, right? Okay. All right. We are quiet. Who will be our reader for today? Let's read some questions and a pulmonary embolism. Our reader for today. Our reader for today. Vida. Okay, Madam Vida, can you read for us?
A nurse answers a call light and finds a client anxious, short of breath, reporting chest pain and having a blood pressure of 88/52. On the cardiac monitor, what action by the nurse takes priority? A. Assess the client's lung sounds. B. Notify the rapid response team. C. Provide reassurance to the client. And D. Take a full set of vital signs.
This one is easy. It's easy. Let's answer and move ahead. Hey, okay. Assess the client lung sounds. Okay. I see. A, D, okay. A, okay. Hey. What if the answer is D? What I'm just saying it. What if the answer is D? What if?
Wasaki.
Yes.
So I'm using the rationale you gave some time ago when we're doing chest tube. You said that
Okay.
when we are checking the patient and then, like when there is a condition and then between the patient and the monitor, the first thing you do is to check the patient. So once there is an assessment, I think I should assess the client's lung sound before
Do you think
before I notify the rapid response team.
Do you think vital signs is not part of assessment?
Oh, it's part of assessment.
So we have two assessments here now.
But since it is respiratory condition,
Okay.
I will channel to that side.
Okay. All right. Okay.
Ooh.
Answer is B. Okay. Mommy, you had the right answer. So why did you pick B, Mommy? Why did you pick B?
As you said earlier, we have two assessments, and looking at the pressure, the blood pressure, it's cardiac output is very low, and it's the patient who is having shortness of breath at the same. So with this one, two assessments at the same time, I just ignored. I tried to choose the B. That was my reason.
Is
Okay,
it a
but
strategy? Can you use this as a strategy to answer questions?
What he's
Like if you
saying
see
is
two assessments, then you ignore one.
no. Can you listen to what I'm about to say? Okay. Hey, please mute up. Okay, so this question, the reason why, aside the rationale we are going to read, but the reason why they will go for B, or I'll also try and side with the B, is because reading carefully in the question, assessment has been done already. Patient has anxious, shortness of breath, reporting chest pain, blood pressure 88. Have you done an assessment already? So assessment, which assessment again? Anxiety. You've assessed and know that patient has anxiety. You've assessed and realized that patient has shortness of breath. You've assessed patient has chest pain. You've assessed BP is low. So assessment then view. Which assessment again? So quickly go ahead and call a rapid response team. Okay. All right. So B, the client has manifestation of pulmonary embolism, and the most critical action is to notify the rapid response team for speedy diagnosis and treatment. The other actions are appropriate also, but are not the priority. So please, it's an endless fake. If assessment is done, the question again, don't do assessment again. Continue with the management or interventions. Okay, it's an endless step. If assessment is done, the question again, don't go for assessment. Continue. with your interventions. All right. So answer is B. Next question. Yes, next question. Madam, Bada, please read.
A client has a pulmonary embolism and is started on oxygen.
Okay.
The student nurse asks why the client's oxygen saturation has not significantly improved. What response by the nurse is best? A. Breathing so rapidly interferes with oxygenation. B. Maybe the client has respiratory distress syndrome. C. The blood clot interferes with perfusion in the lungs. D. The client needs immediate intubation and mechanical ventilation.
Did you know the team with the most valuable squad at the 2026 FIFA World Cup in the United States is worth over $1.7 billion?
Okay, so this one is easy, right? Okay, this one I think is easy, right? All right, see. So, I mean, this one I spoke about this ventilation perfusion mismatch. I told you. Okay, so a large blood clot in the lungs will significantly impair gas exchange and oxygenation. Unless the clot is dissolved, this process will continue unabated. Hyperventilation can interfere with oxygenation by shallow breathing, but there is no evidence that the client is hyperventilating. And this is also not the most precise physiologic answer. Respiratory distress syndrome can occur, but it's not likely. The client may need to mechanical ventilator, but concrete data on FiO2 and SiO2, the nurse cannot make that judgment. So, I mean, there's ventilation perfusion mismatch in this question. After reading this question, you should just know that the patient has ventilation perfusion mismatch. So, although patients can get oxygen, but the lungs are not perfused. Once the lungs are not perfused properly, automatically, it can even interfere the integrity of the whole lungs, okay? And it can still not allow proper gaseous exchange, okay? All right. Next question, Madam Ryder.
Okay. A nurse is caring for 4 clients on intravenous heparin therapy. Which laboratory value possibly indicate that a serious side effect has occurred?
Okay.
A. Hemoglobin 4.2. B. Platelet count of 82,000. C. Red blood cell count of 4.8. D. White blood cell count of 8.7.
Okay, I didn't talk about this, but if someone should know, I will explain the rationale. Someone should know the answer. I will explain the rationale why it is so. I will explain. Okay, I'm seeing B. I'm seeing B. Okay, so you are going for B. What those picking B, one should give an answer why it is B. Why it is B.
I think the patient is getting heparin-induced thrombocytopenia.
Okay.
Because
heparin-induced. Okay, please continue.
I'm in class. Sorry. I think the patient is getting heparin-induced thrombocytopenia because the heparin is breaking up the how should I say, the clotting factors that would have made the blood to clot if the patient is bleeding. So there's excessive breaking up of the clotting factors.
Okay. All right. So, yeah. She is right. Okay. There's a condition we call heparin-induced thrombocytopenia. Let me just type it. Heparin-induced thrombocytopenia. Okay. Please, when you start giving thrombocytopenia, I made a mistake. It's thrombocytopenia. Please take note. When you start giving heparin to any patient at all, for any condition at all, and the patient platelet count starts dropping lower than 150,000. In fact, the normal platelet count for any patient is 150,000 to 400,000. So, if you give heparin to any patient at all, and the patient platelet count starts dropping less than 150,000, there is something we call heparin-induced thrombocytopenia. There's a breakdown of the patient's platelet count or platelet levels. What causes this is an autoimmune reaction to the platelet. Some individuals say they don't like heparin. They are allergic. Let me put it that way. They don't like the heparin. So the moment you set up heparin to infuse, their immune system begins to act against the heparin. Now, once they act against the heparin, by a lot of factors, their platelet count begins to get broken down and they begin to go down. This is what we mean by heparin-induced thrombocytopenia. So their platelet level starts dropping below 150,000. So this is what heparin-induced thrombocytopenia. You start heparin for a patient, their platelet count starts dropping below 150,000. Please, this is heparin-induced thrombocytopenia. Or sometimes they will say it start dropping 50% or start dropping more than 50% of the patient baseline. This is heparin-induced thrombocytopenia. Now, what should you do in this instance? Quickly stop the heparin because there's a reaction. Stop the heparin as soon as possible. So first thing, stop the heparin. First thing you do, stop the heparin. Once you stop the heparin, you switch from heparin to what we call factor. I'm typing everything in the chat box, so pay attention there. Factor XA inhibitors. Factor XA inhibitors. Example, agatroban, dabigatran, apizaban. Please write them down. Apizaban. Yeah, someone who has added one. Rivaroxaban. When I say, why are you saying Okay, so you got this question on the ankles. A question on the ankles. A 55-year-old man admitted to your ward with pulmonary embolism was prescribed heparin. Whilst the heparin was infusing, patients checked, the nurse checked the patient platelet count, and patient platelet count was less than 150,000. What should the nurse do first? The first thing, stop the heparin. First thing, stop the heparin. Okay, good. After stopping the heparin, what should the nurse do? What medication the nurse give? You switch to factor XA inhibitors. Example, apizaban, rivaroxaban, dabigatran, or rivaroxaban. Okay, so these are examples of the factor XA inhibitors. See, you don't bother yourself with why we are giving this drug. I don't want you to go and I don't want you to bother yourself with all this anatomy, not even anatomy, the mechanism behind these things. Do you know, even in this condition, whilst patient platelet is breaking down, they don't bleed. They rather have clottings. Have it at the back of your mind. These patients, despite the fact that their platelet is dropping, they don't bleed. They rather have clottings. It is a whole lot of things. I don't want to go in there. We have a lot of we have something we call factor P4. Okay. In fact, it doesn't make sense here. So you don't worry. Just know that if a patient is taking heparin and eventually their platelets start dropping, this is what we call heparin-induced thrombocytopenia. Stop the heparin and give factor XA inhibitor. Example, the apizaban, dabigatran, agatroban, rivaroxaban. That's all. All right. So the answer here, let's go for B. Okay. So the answer is B. So the platelet count is low and it could indicate heparin-induced thrombocytopenia. Okay. All right. Oh God. Next question. Yeah, Manavida.
Okay. A client is being discharged soon on warfarin. That's Coumadin. What menu selection for dinner indicates the client needs more education regarding this medication? A hamburger and French fries. B, large chef salad and muffin. Sorry. C, no selection. Spouse brings pizza. D, tuna salad, sandwich, and chips.
Yes.
What's menu selection for dinner?
So this one is simple. You are just going to select the one that is high in vitamin K because it will interfere with the warfarin. That's all. because the patient is being discharged on warfarin, right? And then which of the dinner selection indicate that the patient needs more teaching, meaning the patient picks a wrong option. So they need more teaching. You get it? So the answer is B. So warfarin works by inhibiting synthesis of vitamin K, depending on clotting factors. Foods high in vitamin K thus interfere with its action and need to be eaten in moderate. So I mean that is all, right? So a large chef salad and muffin are high in vitamin K. Okay. Yes, Vanavada. Next question.
A client is on a ventilator and is sedated. What care may the nurse delegate to the unlicensed assistive personnel, as a UAP? A. Assess the client for sedation needs. B. Get family permission for restraint. C. Provide frequent oral care per protocol. D. Use nonverbal pain assessment tool.
Okay. UAPs, what do they do? UAPs, what do they do? They do what? ADLs, activities of daily living. UAP, activities of daily living. ADL. All right, C. So the client is on mechanical ventilator, needs frequent oral care, which can be delegated. In fact, let me go back. You don't delegate what you can eat. As a nurse, don't delegate what you can eat. Eat, EAT. E stands for what? Evaluation. A stands for assessment. T stands for teaching. So question 1, A, option A, assessment, it is wrong. The last question, D, assessment, is wrong. So you don't use any of this. So you go for a simple, okay? And you don't give family permission for restraint. So that is it. With chlorhexidine, yes, chlorhexidine, yes, that is it. All right. Okay, so we are done. We are done. So the answer is C. The answer is C. So we are going to the next question. Oh, yes, please. Any final question on pulmonary embolism? Are we following? Are we learning something today?
Yes, sir.
Yes, please.
Okay, let's do OSA. We have some 30 minutes to 6. I'm thinking I can finish OSA. Though I'll not rush. If you don't finish, you continue tomorrow, don't worry. But OSA is not that broad, so all right. So OSA, obstructive sleep apnea. Another interesting topic, but easy to capture. Okay, so OSA, okay, obstructive sleep apnea. All right. So when you see OSA, what comes into mind? OSA, please, we are done with PEO. So bring your mind here. Bring your mind to OSA, okay? Bring your mind to OSA. Just take your mind from PE. We are now on OSA. All right. So let's continue. So once you hear the word OSA, the word, just the wording, obstructive sleep apnea. Just from the wording, we are learning something. Obstructive, something is obstructing something. Can't you pick it? Yes. Something is obstructing something. So we get some obstruction somewhere. Sleep. Okay, so there can be obstructions in sleep. OSA. Then apnea. Apnea simply means cessation of breath. When you hear the word apnea, apnea means cessation of breath. Cessation of breath. Okay, good. So once you hear obstructive sleep apnea, something comes to your mind. Okay, so probably the patient get obstructed in sleep and they have cessation of breath. Before you even think about something, just from the first glance at the name, something obstructed in sleep and the patient has cessation of breath. This is OSA. This is what OSA. So let's read what is on my screen. Then I'll use to explain OSA. Okay. Let me read this on my screen. OSA simply means obstructive sleep apnea. Okay, obstructive sleep apnea. Obstructive sleep apnea. All right. So it's characterized by partial or complete airway obstruction during sleep that occurs from relaxation of the pharyngeal muscles, the muscles around your neck, around your pharynx. The result is repeated episodes of apnea that is greater than or equal to 10 seconds, and hypopnea. Hypopnea is shallow breathing or slow breathing. That is decreased ventilation less than or equal to 50%, which causes hypoxemia and hypercarbia. Hypercarbia is same as hypercapnia, high CO2 levels. Okay, let me further read. Next paragraph. During apnea, desaturation and hypercapnia occur, causing patient to suddenly wake up from sleep and patient momentarily breathing to restore airflow. All right. So what is the head and tail of all this reading I read? Kindly just listen to me at this moment. Let me just give you what is going on the pathophysiology, what is going on in OSA. So what is going on in OSA is simple. Patient was sleeping. Then whilst they were sleeping, they had a cessation of breath while they were sleeping. How did they get the cessation of breath? The airway gets obstructed. What caused the airway to get obstructed? By a relaxation of your pharyngeal muscles. By a relaxation of your pharyngeal muscles. Are we okay? A relaxation of your pharyngeal muscles, the muscles around your pharynx. Okay, your muscles around your pharynx. One thing is that, for example, people who are obese or obesity patients, people who are very, very big, they have fat neck, more fat around their neck. Okay, more fat around their neck. When you are sleeping and you are fat, this is the reason why I'm explaining to you the reason why patients who are fat most of the time snore when they sleep. They snore because while they are sleeping, their fat neck begins to compress on your airway, your pharynx, muscles, and everything in the airway. So air does not enter properly. So once the air is trying to when the air is trying to enter that narrowed airway, it is forcing its way throughout that airway. It begins to create turbulence. So you hear that sound. Why? Air is struggling to pass through your airway. The air is struggling. Your neck is too big because you are fat, and that neck is compressing on the airway. So air is trying to force its way there. It is struggling. So you begin to hear a turbulence causing the sound we hear as snoring. So when you are fat, when you take in alcohol, when you take in some things, that will reduce your body to dilate. Or you are sleeping. You know, when you are sleeping, you are down. When you are sleeping, everything about your body goes down because you are relaxing. This will cause your pharynx, the muscles in your pharynx, to also decrease and relax. Once they decrease and relax, airway becomes a problem because once they are relaxing, they fall down, or let me say they fall. They are not constricting, they are not standing. You know, when something is constricted, it is standing. Whereas when something is dilated, they are relaxing. Good. So when you are sleeping, you are relaxing. You are now relaxing your body. Your brain is relaxed. Your entire body is relaxed. So this will cause the muscles around your pharynx to also relax. So the muscle tone begins to decrease. It relaxes. Once they relax, it falls off. So even sometimes, even your tank can fall back because you are sleeping, you are relaxing. So nothing controls your tank properly. So tanks can even fall back and occlude your airway. So when this whilst you are asleep, air does not pass through the air, your airways properly, your nose, your pharynx, your trachea, because your larynx, your pharynx muscles are relaxing. And once they are relaxing, they are closing up. So this prevents adequate air to pass through your airway to your pharynx. Okay, so if someone even have issues like, let's say, obesity, then it even spoil the issue because already your fat is compressing the airway. So when this happens, eventually, because there's struggling, or the air is struggling to pass through to your lungs, eventually it stops, or the airway becomes closed. Sometimes complete, as you can see on my screen, the definition, it can be partial or complete airway obstruction. Because once the airway becomes relaxed, it can totally obstruct airway or airflow. Once this thing occurs, you begin to seize breath because air does not enter your lungs. You begin to seize breath for 10 seconds or more. Now, the moment patients begin to seize breath for 10 seconds or more, they begin to suddenly wake up so that they can now restore their breath. So let me tell you, if you sleep with someone that at a point in time in their sleep, they wake up suddenly and they begin to breathe faster, please, the patient might be having OSA. That person might be having OSA. Because under no circumstance should you wake up, if not a bad dream, you shouldn't wake up suddenly in sleep and they begin to breathe faster. The patient or that person might be having OSA because the airway is blocking, seizing breath. So they begin to wake up suddenly to breathe faster to restore breath so that they can now sleep normally. This is OSA, a relaxation whilst you sleep, because you are relaxing whilst you are sleeping. Your muscles begin to relax, the muscle tone decreases, preventing proper flow of air into your lungs. This is called hypopnea because at one time there's slow breathing because the air is closing, the air is closing. So the air entering is not much, so slow breathing. Then eventually you got cessation of breath. Boom. Cease breath. Boom. Then once it begins to exceed 10 seconds, patient begin to wake up from bed suddenly just to restore blood flow. Okay, so this is OSA. This is obstructive sleep apnea. You're sleeping and your airway is obstructing. Your airway is becoming obstructed by what? By a relaxation of your pharynx. Then you begin to have a cessation of breath. We say this is what? OSA. Please, is the explanation okay? Is it clear? Is it clear? Hello, class.
Yes, please.
Okay. All right. Okay. So this is OSA. Now, one thing is that the more breath is seized, the more the airway is collapsed or completely obstructed. Let's say your larynx muscles has decreased, they are relaxing, so they occlude the airway, they completely obstruct it. The more it is obstructed, the more oxygen cannot enter, the more carbon dioxide cannot come out because you are not breathing. So the more this thing persists for long, carbon dioxide can stay in your lungs. You can get what we call hypercapnia. And you can also get hypoxemia. Why? Because oxygen does not get into your lungs. To get diffused into your blood, it can lead to hypoxemia. Therefore, this is OSA. All right. Risk factors. Charlie. Hello, class. Please, a minute. Okay. So let's continue. Okay. Let's continue. So risk factors to OSA. One, obesity. I explained it already. When you are obese and you are fat, plenty fat deposit, plenty fat deposit around your airway. Plenty fat deposit, okay, around your airway. So what is going to happen? That fat deposit that fat deposit around your lungs can begin to compress the airway. Can begin to compress the airway. It begins to compress the airway. Once it begins to compress the airway, what happens is that it further obstructs the air when you are sleeping. Because when you are sleeping, already the body is relaxing. The muscle tones around your larynx are already relaxing. And then you are obese. So two things, two to one God. You are relaxing your body, whereby the airway is closed. And secondly, you are obese. So all the fat deposit is further closing out the airway. So air does not enter. This can lead to OSA. Okay. So obesity. 2, aging. Okay, so for aging, it is normal. For aging, we know the reason why aging is a risk factor, a lot of conditions. When you are aging, you know how your muscles looks like. For example, if you are young, you are strong, your skin looks fresh, right? Your muscles are strong, your skin is tight, fresh, strong. So you have proper muscle movement, okay? But the more you age, the more you lose your muscle tone. The more you age, the more you lose your muscle tone, okay? Good. So the more aging is happening, the more individuals who are aged cannot have a proper muscle tone around their neck, around their larynx, and this can contribute to a closure of the airway when they are sleeping. All right. 3, neck circumference greater than 16 inches. Who can tell me the normal circumference of the neck? Yes, for a normal human being. Yes, who can tell me? Yes, normal neck circumference. Oh, all right. So as a man, you should have your neck circumference around 15.2 inches. And then for women, around 13. Okay, around 13. So if you are getting your neck circumference becoming bigger, more than 16, it means that you have a big neck. It can compress on your airway and can occlude the airway when you are sleeping, which can lead to OSA. Then next point, medications like sedatives. Let me see. Medications like sedatives. Medications like sedatives, okay? So we all know what sedatives can do to a human body. We all know it. So if we give you, let's say, morphine, we give you fentanyl, it sedates you so that you sleep. So it calms the sleeping center in your brain. It brings it down. It lets you to sleep. Okay. So some centers in the brain, like respiratory center in the brain, will be reduced. Okay. So once you give a patient a sedative, you are sedating the patient. So some centers in the brain, like respiratory center in the brain, that will even help you to even think. That will even help you to breathe properly. These centers in your brain will be reduced. So this can affect your airway. Once the airway is affected, okay, once the airway is being compromised, simply because we give sedative, because the respiratory center has been reduced, it can affect how you breathe in and out whilst you are asleep. Okay. All right. So that is something why sedatives can cause OSA. Because if you give a patient morphine and they keep on sleeping and sleeping and sleeping, at a point in time, their airway becomes very, very relaxed. It gets closed and it can affect what? Breathing. Okay. Whilst you are sleeping. The next one, alcohol. Alcohol is like a sedative. Okay. When you drink alcohol, you are almost down. You are not active. You are relaxed, your airway can be relaxed. So you see, alcohol can also predispose you because it keeps you at a relaxation state, which can further lead to what? Can lead to OSA. Okay. All right. So that is that for risk factor for OSA. All right. Is there any question on the previous slide? Any question on the previous slide? Any question?
Yeah, I have a question.
Yeah, you can ask.
Yeah, I wanted to. Okay, when I was in uni, anytime I wake up late, maybe by 3 a.m., 1 a.m. to study, after I finish and I want to sleep, I tend to have sleep apnea. So I was listening when you were saying obesity. I'm not a big person. I'm not old. I'm not, I don't take sedative drugs or alcohol. So what could be causing that? I notice it then anytime I finish studying late and I want to go to sleep, I tend to have sleep apnea.
How do you know you have sleep apnea? Do you have cessation of breath while sleeping?
Yes, I do.
That wakes you up whilst you are asleep.
Yeah, I have
Have you
cessation
checked
of breath for like some seconds. I struggle. Sometimes my roommate will notice it. They have to hit me to wake up.
Okay. Have you checked your neck circumference?
Not really.
Okay. So try and check your neck circumference as well. And then probably you might want to do a test. Well, is it still there? Is the issue still there?
I've not really noticed it. I try to avoid waking up by that time to read, but I haven't noticed it since I left school. But
Okay.
sometimes once in a while,
Yeah.
I notice it. Maybe when I'm overstressed and I go to bed, I
Yeah,
notice
I was about to say that. See, sometimes you were sleeping the night. You are too tired. When you are too tired and you sleep, you relax too much. Okay, so there's an increase in the closure of the airway. Okay, there's an increase in the closure of the airway because you are too relaxed. Too much tiredness will cause you to get too much relaxation. You get my point. So all these things can further cause you to relax too much and occlude the airway. That is one. Two, you might want to secondly check your neck circumference, and probably you might want to check how your brain regulates itself when you are asleep, because sometimes with the brain can be an issue. Okay, all right, but I mean, I think it is tiredness. For me, I think it's tiredness. You maybe you are too tired, you are too stressed out, so you relax too much, and therefore it causes that occlusion. Since it is not persistent these days. Okay, all right. Are you good? Please, any question? Class, please, a minute. Yes. Someone too is saying that sometimes position in sleep also matters for sure. Okay, sometimes the way you sleep, if you sleep tilting your head too back, your tongue can occlude the airway. Okay, some people when they sleep, I mean their pillow, they even go beyond their pillow. Okay, it can even occlude the area. So all right, so let's look at the signs and symptoms. Okay, some key signs and symptoms of OSA. Okay, some key signs and symptoms of OSA. One, apnea. Apnea. Please never conclude that a patient have OSA without apnea. In fact, if a patient is snoring while sleeping, a patient wakes up to breathe. Okay, that one could mean that there's apnea. But if a patient is snoring, a patient have, let's say, early morning headache, and then they don't have cessation of breath while sleeping, please, there's no apnea. I'm sure we've been sleeping, I mean, sleeping with people who snore during sleep, but they don't have OSA. They've not been diagnosed with OSA. They are fine, they are normal. Please, the key sign to diagnose OSA is cessation of breath more than 10 seconds or 10 seconds or more. It is the apnea. Because once the airway gets occluded, air does not enter, air does not come out. So you cease breath. Okay, this is what we call apnea. More than 10 seconds, not 5 seconds, not 7 seconds, 10 seconds. All right. Two, snoring. I've explained the snoring already. Once the airway gets relaxed, and does not allow proper air to pass through, what happens? Air begins to force its way through the airway. It creates a turbulence. Once it begins to create that turbulence, you hear that sound. It is creating a turbulence in the airway. That is why you get snoring in OSA. When the airway occludes, the airway gets relaxed, the airway gets closed, and the air is trying to force its way in and out. It begins to create a turbulence in the airway. You hear the sound, and we call it snoring. 3, early morning headache. Of course, you couldn't sleep properly. You sleep 1 hour, you wake up, you breathe, you go back, you sleep again, you wake up. I mean, consistently throughout the night. So you wake up with headache. You are stressed. You didn't have proper sleep. So they're going to have early morning headache. 4, poor concentration. Tell me anyone who can concentrate better when they don't have proper sleep. Nobody. Okay. So they have poor concentration in the day when they are studying, when they are learning. They have so this condition, if it affects people, they have poor academic issues. Okay. In fact, they are bad at school, because at school they will be sleeping at school. Okay. So they have poor concentration because they don't sleep properly to get proper energy for the next day. Then 5, because they were waking up several times during sleep, in the day they will be sleeping, so they get daytime sleepiness. Okay, they get daytime sleepiness. Okay, daytime sleepiness. All right. Then 6, chronic fatigue. Imagine you couldn't sleep properly. You wake up, you get tired. You just get tired. Because, I mean, sleep is a strategy to renew your strength for the next day or for the next, the next task ahead of you. Anyone who sleeps better, most of the times performs better, because you are always re-energizing yourself. Because once you sleep, you calm yourself down, renew your strength, and continue. But you don't sleep properly. Within 5 hours, you'll be waking up like 10 times within 5 hours because of cessation of breath, just to restore your flow. So this is going to cause what? Chronic fatigue during the day. 7, low saturation. Of course, oxygen is not entering your airway. Carbon dioxide is not coming out whilst you are sleeping. So they can get low saturation. Then lastly, 8, doesn't feel rested upon awakening. They don't feel that they have been able to rest well when they wake up in the morning. It's a key sign of OSA. So you read this question. A 30-year-old woman was admitted to your ward in the morning. Upon assessment, patients verbalize that anytime they wake up, they don't feel rested after sleeping. And then they wake up several times in the night to breathe. Also, when they are moving around during the day, they have poor concentration. Please, what is this? This is OSA. All right. So that is that for the clinical intervention. So nursing interventions, the clinical manifestation, nursing interventions. The diagnostic test, we'll go over the diagnostic intervention, okay? How we can diagnose OSA. Probably that one, you start from that one from tomorrow, okay, because of our time. So let's just go through the interventions, okay, the interventions. 1, sleep on the side or with the head elevated. So someone even raised that point in the chat box, Madam Martha, that sometimes how you even sleep can cause OSA. So positional therapy, okay? So it is better that if you have OSA, you sleep on your side, you sleep on your side, or you sleep with the head of the bed elevated, okay? You sleep on your side, or you sleep with the head of the bed elevated. This will not allow your tongue to fall back so that it will occlude the airway. 2, controlling the weight, okay? If you are too fat, please try and control your weight. Obesity will cause your neck to become bigger. It will occlude or close, or it will further obstruct the airway. So control your weight. Next point, limit sedatives or alcohol intake 3 to 4 hours before sleep. I told you, sedatives reduces the respiratory center. Sedatives makes you relax more. And a sedative makes you relax more. So if it even wasn't the case, so reduce or limit alcohol and sedatives 3 to 4 hours before sleep. Next point, reinforce the dangers of driving during the day due to daytime sleepiness. You see, patients should not be advised to drive when they have this OSA because they don't sleep at night. So in the day, they sleep a lot. Please, if you allow them to drive, accident will occur. So never allow them to drive. Always, there should be someone driving them. If they drive alone, they can get an accident because they will be sleeping during the day. All right, next point. No napping during the day. They shouldn't nap during the day because already with you having an issue with this condition, you suffer at night to sleep. You suffer at night when you are sleeping. Okay, so why should you even worry yourself sleep in the day again? You will not even get any sleep at all during the entire day. So to allow them to at least get some limited sleep, tell them that they shouldn't sleep during the day. All right. Then lastly, no bedtime snacks. Why do you think they shouldn't take bedtime snacks in OSA? And eating the what does it do with airway? Eating the is normal. What does it do with airway? So why bedtime snacks are avoided in OSA? Why? Why? Yes, anybody to try. Don't you think they can get reflux? Eh? Okay, so already as a person, already when you are sleeping, you are relaxed, your bodies are relaxed. I mean, so a lot of things are going on. Okay. So one thing is that when you eat, so we don't allow you to eat. Well, when you eat before you sleep, right? Before you sleep, it allows you to have a reflux, which can cause what? Which can cause even sometimes it can cause aspiration. Sometimes it can cause issues in your esophagus. Okay, so it's not helpful. It can cause inflammation, swellings in your airway. Okay, so please take note. And in fact, if you eat right after sleeping, sorry, if you sleep right after eating, bedtime, you are on the bed and you are taking Coke, taking biscuits, then when you are done to sleep, do you think there's going to be proper digestion? No. The food, you are going to sleep on your stomach, it will cause a reflux and it's not going to help your throat. So a patient who even have issues like this should not even be eating at night. Because we need proper digestion for sleep. If the food doesn't digest properly, it will even worry you for your sleep. So that is why you don't have to sleep or eat late before you sleep if you have OSA. Okay, it can trigger acid reflux and can cause pressure in your diaphragm and can even lead to other factors. All right, so that is it. Then other interventions, CPAP and BiPAP. All right, what is CPAP? CPAP stands for continuous positive airway pressure. Okay, continuous positive airway pressure. BiPAP, bi-level positive airway pressure. Okay, bi-level positive airway pressure. When a patient have OSA, usually we start with BiPAP. BiPAP. What is BiPAP? BiPAP, it gives only oxygen. It doesn't take out carbon dioxide. Oh, sorry. What am I saying? Sorry. BiPAP is bi-level. It gives oxygen and take out carbon dioxide. Sorry. Okay, point of correction. BiPAP is by two. So it can do two things at the same time. It can give you oxygen. It can take out carbon dioxide. It can give you oxygen. It can take out carbon dioxide. BiPAP. But sometimes, because it is doing two things at the same time, it doesn't help with oxygenation. So most people would always say, don't cope with the BiPAP. So it is better if they don't cope, you put them on CPAP. CPAP is continuous positive. So that one, we just supply oxygen, continuous, just supply oxygen so that the patient can have adequate oxygenation to prevent respiratory failure. You supply oxygen continuously. So it delivers a steady flow of air to keep the airway open and improve respiration. So if we start with the BiPAP and it doesn't help, please switch to CPAP. Just give oxygen. You don't worry about the carbon dioxide. Just give oxygen so the patient can have oxygen. Priority first. We just want to save the patient from death. Okay, so just supply oxygen steadily to restore respiration. Then later, we can now say, let's bring out the carbon dioxide. All right, so that is that for CPAP. Okay. All right. So now the test you can do for is polysomnography. Should we do it? It is almost 6. Should we just go by it? I
Yes,
want to hear from you.
please.
Okay. Please, the response. It is not coming out. Everybody are saying, but
Yes.
I feel like okay, let's just try and then go through what this. If you close around 6:05, 6:10, it's normal, right? Yeah, it's normal. So the test we usually do in OSA is polysomnography. Polysomnography. So what should you know for polysomnography? Now, please take note. This test is not only done in OSA. It is done to check a lot of things. It can even be done to check your brain waves. It can even be done to check your eye movement and muscles. Okay, so let's just go over OSA. Polysomnography. It is a sleep study that involves monitoring various physiological parameters during sleep. So once you are asleep, it measures a lot of things to diagnose sleep disorders. Any sleep disorder at all, not only ASA. Any sleep disorder at all, not only OSA. It typically involves monitoring your brain waves, your eye movement, your muscle activity, your heart rate, your respiratory rate, your chest and abdominal effort, and saturation level. Okay, all these things are measured before you do polysomnography. Okay, so what should you know? So before the procedure, please, these are the NCLEX tips for polysomnography. Don't miss them. Don't miss them. For polysomnography, don't miss them. Before the polysomnography, what should you do? Or what should you tell the patient? One, maintain your regular daytime schedule. It is not anything special that you are going to say, hey, don't do this, don't do that. Just maintain your daytime schedule. Two, avoid napping on the day of the study. So if your study is around 4 p.m., please don't sleep before 4 p.m. If your study is around 9 p.m., don't sleep before 9 p.m. because we want you to sleep deep for us to know how you're sleeping or how do you cope with the sleeping. Because if you take nap in the day, on the day before the study, let's say your time is 9 p.m. and you slept around 4, 3, and you wake up at 6, you will not sleep properly when the time is due for the test. You get it? But we want you to sleep deep properly so that we can now identify the mistakes and the abnormalities. So tell them to avoid napping the day before the study. 3, avoid caffeine, alcohol, and sedative for 24 hours before the study. So you don't want anything to act on the brain to stimulate or sedate the patient so that they can sleep properly. They can have a normal sleep, not a drug-induced sleep. Because if you sedate a patient, they will sleep under the influence of the drug. So we want them to sleep naturally for us to get a proper and accurate finding. So avoid alcohol, caffeine, sedative for 24 hours. Wash and dry your hair, but do not apply hairspray, oil, or gel because the electrodes will be applied to your hair and your head. So to get accurate results, you can just wash and dry your hair, but don't apply any gel, oil, or hairspray. Then take your regular medications or meal. As I'm saying, you can take any medications except sedatives, caffeines, okay? Sedative and caffeine, but you can eat any food you want to eat, okay? It's just sleep, you're going to sleep. All right, so that is done before the procedure. Then during the procedure, what should you do? During, monitor the brain waves to detect abnormalities like seizure. Sometimes patient can seize whilst the procedure is going on. Please, this procedure most of the time is done by doctors. Okay, it's done by doctors. Nurses rarely do it. It's done by doctors the most. So you, the nurse, your teachings are the before and the after observations. Okay, all right. But well, you can ask questions on the during. So you monitor the brain waves and detect abnormalities. But these things are done by specialties. Okay, or specialists. Okay, and they will examine you properly under a machine. Those who have been trained to use the machine. Okay, all right. Monitor eye movement and then REM. Okay, REM. So rapid eye movement. So you monitor all these things. Okay. Monitor heart rate and rhythm. Is the patient breathing faster whilst asleep? And then the patient means that then it could mean that the patient is having cessation of breath too. Is the rhythm normal? Is it faster? then it means that the patient is trying to compensate. It could mean a sign of OSA. So you monitor all these things. Monitor respiratory effort. Example, oxygen saturation, chest and abdominal movement. Is the patient breathing with intercostal muscles? Are we seeing a proper rise and fall of the chest? All these things could signify you that the patient, okay, this one, the patient does not have OSA, or this one, patient have OSA. Okay. All right. Next point, monitor muscle activity and detect disorders like periodic limb movement disorder. Sometimes when a patient have periodic limb movement whilst asleep, it could mean a sleep disorder. Okay, so you monitor all these: respiratory rates, brain waves, oxygen saturation while asleep. But all these things will prompt you: is the patient having apnea? Is the patient have a normal SpO2 level whilst asleep? If the patient's SpO2 start dropping less than 95, it could mean that the patient having sedation of birth. All these things can begin to prompt you of ASA. So after the procedure, what should you do? One, document the procedure and observations. Then two, document patient perception about the procedure and report any abnormality for further investigation and diagnosis. So this is what you should know. Please, the most important is the before. No napping on the day of the study. Avoid alcohol. Avoid alcohol. I said alcohol. Avoid alcohol, caffeine, and sedatives. Wash your hair dry and take all medications and meals. Nothing special, but do these things. And after you report and document. This is for polysomnography, a study we use to assess for sleep disorders. All right. So complications of OSA. Complications of OSA. One, negative work performance. Of course, you are always tired at work. So there's going to be a negative work performance. Two, motor vehicle collisions. You are tired, you are driving, accident. So they are advised not to drive because you are always tired, you are sleeping on the day, accident. Three, hypertension. Someone may ask, okay, let me even leave the hypertension and then the heart failure there. I'll come back to it. Four, poor academic performance. Of course. Poor academic performance, of course. Okay, because someone who have this issue will not consider at school. You are always sleeping in class. You are always sleeping in class. So this patient will have what? Will have a poor academic performance. Then mood changes. Mood changes. Mood changes. Okay, mood changes. So there will be mood swings. Today is like they are active. The next day they are not active. Okay, all these things can okay. Now let me go to the middle points over there. Why do we get hypertension in OSA? Okay, why do we get hypertension in OSA? So sometimes when oxygen level begins to drop, what happens? Patients begin to perceive stress. Patients begin to perceive, hey Charlie, why can't I sleep? Why can't I sleep? Begin to stress out. When you stress out, what happens? There will be activation of what? Your sympathetic nervous system. And once the sympathetic nervous system is activated, your heart rate will jump. You can get heart failure when hypertension occurs, or when the heart rate begins to occur consistently. It can cause narrowing of the blood vessels. It can lead to heart failure. So that is how these things can result from OSA. As simple as that. This brings us to the end of OSA. Any question on OSA? Any question on OSA? Any question on OSA? Have we learned something today? OSA.
Yes.
Okay. Any questions? So you don't have any question, right? We don't have any question, right? We are good, eh? If you meet any question on the class on OSA, and then what do you call it? You are good to go, right? Okay. All right. Since you don't have any question, please, we are in the class. So I don't get any question from you guys. Why? You don't like asking questions?
It's because we understand.
Osaki,
Okay. Yes.
please, can inflamed tonsils cause OSA?
Yeah, tonsillitis, right?
Yes, because I know of one small girl. She when she sleeps, she was snoring, like she snores a lot. So
Okay.
one day the mother told me that like she was sick. So the mother said, oh, they booked her for tonsillectomy. That that is what is causing she sometimes gets apnea. So I
Really?
was
Okay.
yeah, so I
Yeah,
don't
yeah.
know.
So sometimes, sometimes it can occur because I mean, inflammation, 5 signs of inflammation: pain, fever, loss of function. What again? Swelling. If your airway is swollen, it will occlude or prevent air to get into your lungs. This can cause OSA. So sometimes it can be a factor. Okay. Yes, it can be a factor. All right. Okay, that's fine. That's fine. Okay. Okay, so if there are no more questions, all right, let me give you one drug. One drug we can give here. All right, so see, when you sleep too much in the day, because this patient they sleep a lot in the day, they can begin to doze off, and then I mean you are always not active and all those stuff. There's a drug we give to them. We call it modafinil, so that they can stay active in the day. Okay, modafinil, so that they can stay active in the day. Okay, modafinil. Okay, modafinil is given to people who sleep a lot in the day. Okay, okay, it is given to people who sleep a lot in the day so that it can help them. Modafinil. All right. So this brings us to the end of today's class. We are left with only 2 topics to finish everything on respiratory system: cystic fibrosis and I think respiratory syncytial virus. So we shall meet today and try and finish them. All right. Since there are no more questions, let me stop recording.